Dr. Kajeski. The video you are about to watch deals with issues related to child and dependent adult abuse. Iowa law requires that mandatory reporters receive 2 hours of training in the recognition and reporting of child and dependent adult abuse within the first 6 months of employment, and 2 additional hours of training every 5 years thereafter. Viewing this video and completing the certificate of training and test at the end of the video will allow you to meet this legal requirement. This video provides you with information regarding Iowa law and procedures related to the reporting of suspected child and dependent adult abuse. Professional recognition of suspected child or dependent adult abuse is an important function of healthcare providers. During this video, we will provide you with information related to the indicators and other possible medical findings often associated with suspected child and dependent adult abuse. In order to help you assess your understanding of the material being presented, questions are included throughout this videotape. Please answer the questions as they are presented. At the conclusion of this video, please complete the certificate of training sheet. The top original is for your use or file. It can be used to document completion of the mandatory reporter education requirement in the state of Iowa. The copy must be turned in at the conclusion of training or sent to the Department of Social Service. This information is used to update human resource file information to document that you have completed this requirement, and will also be used to contact you in 5 years when you will need to renew your certification of training. If you have any questions or concerns, contact the Department of Social Services at 356-2207. Thank you for your interest in and attention to this very important subject.
That young boy by the name, anywhere I know his face. In the city, the kid's my favorite to see and sing out. I see him every day. Seeing him run outside, looking for a place to hide from his father. The kid half naked and fell to my side. Oh, what's the matter here? I'm tired of the excuses everybody uses to their kid. I stay out of it. But who gave you the right to do this? I can do it to see fit. But get this through that I don't approve of what you did to your own flesh and blood. If you don't sit in your chair, I'll take this back from around my waist. And don't you think that I won't everything answer me and take your time? What could be the offer climate good to it so young an age? If I'm the only witness to your madness, offer me some words to balance out what I see and what I hear. Oh, these cold and lonely things that you do are supposed to do because it belongs to you. And instead of loving the feel of warmth, you've given him these cuts and swords that don't heal through time or release. And I want to say hi, want to say what's the matter here? But I don't dare say what's the matter here? But I don't dare say.
Abuse, as manifested by violence and neglect, potentially affects all people, of all ages and all socioeconomic backgrounds. Family maltreatment is all too common today. It covers a wide spectrum, from those incidents which result in severe psychological or physical injury or even death to the victim, to milder forms which may produce no signs of physical injury. The first type of maltreatment mentioned is the type that results in emergency room treatment and perhaps publicity in the newspaper or on television. Arrests and legal action against the perpetrator usually follow. Most people have a strong negative reaction to this level of violence. Incidents of milder violence are much more common, engaged in by a larger percentage of the population, and are viewed with considerable ambivalence as to whether the behavior is abusive or acceptable. Behaviors in this category might include slapping a child who swears, jerking the arm of a significant other, or sitting a child down hard, labeling him stupid when he fails to follow directions. It's helpful to look at some of the factors that lead to our society's apparent acceptance of family violence. While interest and concern about child abuse, spouse abuse, and dependent adult abuse have become evident in recent years, family violence and abuse are not new developments. In fact, throughout most of human history, children have been identified as the property of their parents. Aristotle said, "The justice of a master or a father is a different thing from that of a citizen, for a son or a slave is property, and therefore there can be no injustice done to one's own property." Ancient cultures often practiced and accepted killing of newborn children. In ancient Rome, a father had the legal right to sell, abandon, kill, or offer his child as a sacrifice. In colonial America, parents were implored to beat the devil out of their children. Stubborn child laws allowed parents to put unruly children to death. Sexual use of young children was common and accepted. Florence Rush explained in her book, The Best Kept Secret, that one religious text stated that a female child had to be 3 years and 1 day of age to be legally betrothed by sexual intercourse, with her father's permission, of course. Male children were sometimes forced into sexual slavery or castrated to produce eunuchs for the palace or harem. The Mary Ellen case of 1874 is seen as the first legal challenge in the United States to the parental ownership rights of their children. In this case, a nurse became aware of a New York City child who was being physically abused and neglected in her home. When law enforcement refused to act on her complaint, the nurse contacted the Society for Prevention of Cruelty to Animals, asserting that Mary Ellen was a member of the animal kingdom. She was legally removed from the home on the basis that as a member of the animal kingdom, she was entitled to at least the same justice as a common dog on the street. Out of this case grew the Society for the Protection of Cruelty to Children, now known as the American Humane Society. They publish yearly statistics on child and animal maltreatment. Children have not been the only victims. Throughout history, women have also been the target of violence in the home. Roman husbands had the legal right to chastise, divorce, or kill their wives. The expression rule of thumb is said to come from Old English common law, which stated that a husband could not beat his wife with a rod thicker than his thumb. Marital rape was considered a contradiction in terms until very recently. Even when laws permitting domestic violence were repealed, victims had little protection from violence and abuse in the home. A North Carolina court broke legal ground in 1874 by ruling that a husband had no right to chastise his wife. However, the ruling went on to say, if no permanent injury has been inflicted, nor malice, cruelty, or dangerous violence shown by the husband, it is better to draw the curtains, shut out the public gaze, and leave the parties to forgive and forget. Historically, privacy and autonomy of the family have been strongly held values in our society. In fact, the statistics paint a picture so startling that we may be tempted to turn away. There are more than 3 million reports of child abuse in the United States each year. In Iowa, approximately 5% of our 625,000 children are identified as suspected victims of child abuse each year. Those are only the reported cases. The actual number is estimated to be 3 times higher. It's estimated that between 2 and 4 million women are battered by their partners each year, and each year 2 to 3 million elderly people in this country are physically abused or financially exploited by their caregivers. 1,500 reports of suspected dependent adult abuse are made each year in Iowa. Family violence is virtually epidemic. Reasons for family violence are widely discussed. Factors such as an increase in family mobility, higher divorce rates, isolation of the nuclear family, substance abuse, and unemployment, to name a few, are often cited as causes. Certainly these factors do contribute to the problem. There may, in fact, be an increase in family violence in recent years, but we really don't know whether the statistics reveal an increase in violence or an increase in reporting of violence. From a historical perspective, there's ample evidence that abuse within the family has existed for centuries. Only recently have we begun to recognize and respond to the need to protect family members in their homes. Legislation has been one response. Child abuse laws were passed in the 1960s, spouse abuse laws in the late 70s, and dependent adult abuse laws in the 80s. We'll be talking about those laws, about what is currently known about patterns and detection of abuse, and about our role in intervening in abuse situations.
In 1946, Dr. John Caffey identified a pattern in infants of subdural hematoma, a collection of blood under the skull, along with long bone fractures. These injuries were the result of violence, but the source of the violence was still not labeled. It was not until 1953 that parents were formally identified as the cause of injury to their children. A few years later, in 1961, the term battered child syndrome was first used by a group of physicians. Media and professional use of this term helped facilitate awareness of the problem, and over the next 40 years, legislation to protect children and later dependent adults from abuse and neglect by caregivers was passed in Iowa and throughout the country. Physical abuse was the first focus. In 1965, Iowa passed a law which encouraged citizens to report suspected cases of physical child abuse to the Iowa Department of Human Services. In 1975, professionals who frequently interact with children were identified as mandatory reporters, who were required to report suspected abuse and who would be held legally accountable for failure to comply. In 1978, the law was expanded to cover sexual abuse and denial of critical care, or neglect. In 1984, sexual exploitation and prostitution were added to child protective legislation. In 1985, periodic training for mandatory reporters of child abuse was added to the Iowa law. Mandatory reporters must now receive 2 hours of training on the recognition and reporting of child abuse every 5 years. In 1988, Iowa passed a law mandating reporting of suspected abuse and neglect by professionals working with dependent adults. In 1993, the child abuse law was expanded to include mental injury and expanded the chemical exposure section to include children of all ages. In 1997, an amendment to the law governing child sexual abuse stipulated that mandatory reporters must report sexual abuse of all children aged 11 or younger, regardless of the relationship of the suspected perpetrator to the child. Permissive reporting was allowed for children 12 and older when the perpetrator is not a caretaker of the child. In 2001, the child abuse law was expanded to include bestiality and manufacture or possession of a dangerous substance in the presence of a child. In 2006, the child abuse law was expanded to include cohabitates with a registered sex offender. In 2010, the child abuse law changed cohabitates with a registered sex offender to allows access by a registered sex offender, and also added allows access to obscene material.
According to the Iowa Code, 3 components must be present before the abuse reporting law is applicable. They include, first, the presence of a child or a dependent adult. Second, a specific incident or pattern of incidents that meets the criteria for abuse. And third, the alleged perpetrator must be a caretaker of the child or dependent adult. An exception to the stipulation that the alleged perpetrator of child sexual abuse must be a caretaker for the abuse to be reportable to DHS was enacted into law in 1997. The law now states that mandatory reporters of child abuse are required to report within 24 hours the sexual abuse or child prostitution of any child aged 11 or younger, and may report the same for a child 12 or older if the sexual abuse was committed by or allowed by someone other than the child's caretaker. The law additionally stipulates that DHS must report child sexual abuse and child prostitution by a non-caretaker to the appropriate law enforcement agency. A child is defined as any person under the age of 18. A caretaker is a related or unrelated person who has the responsibility for the protection, care, or custody of the child as a result of assuming the responsibility voluntarily, by contract, through employment, or by order of the court. An institution or hospital can be a caretaker. Child abuse or abuse means harm or threatened harm occurring through the non-accidental acts of the caretaker. We will next look at physical abuse and behavioral signs that may be observed in children that indicate abuse may have occurred. Physical abuse is defined as any non-accidental physical injury or injury that is at variance with the history given, suffered by a child as a result of the acts or omissions of the person responsible for the care of the child. There are several indicators of physical abuse. Bruises and welts sometimes result from abuse. Whether bruises lead to suspicion of abuse depends on several factors. One factor is the location of the bruises. Bruises which result from accidents usually occur over areas of bony prominences, the areas that would naturally come into contact with hard objects in a fall or collision, such as a child's forehead, knee, or elbow. However, normal locations for bruises are different for children of different ages. An infant who has not yet begun to walk should not have bruises on the shins. On the other hand, a 2-year-old may have multiple shin bruises as a result of normal play activities. A second factor in determining whether bruises may be an indicator of abuse is the number and stages of healing. While it is possible that an active child could end up with an accidental injury resulting in bruising about anywhere on his or her body, if there are numerous bruises at various stages of healing in unlikely places, that child should be carefully assessed for abuse. A third characteristic of suspicious bruising is bruises that resemble the shape of the object that inflicted the injury. Children hit with hands, belts, and cords often have pattern bruises. A birth defect that may appear to look suspicious is called a Mongolian spot or a congenital dermal melanocytosis. This is a benign birthmark that is often mistaken as a bruise. This birthmark is most prevalent among Eastern Asians, Polynesians, Native Americans, Turkish people, and East Africans. In a case like this, it is good to get a good history and to seek a medical consultation if you have questions. Burns may result from abuse. Cigarette burns are fairly easy to recognize because they are circular and similar in size. Often the burns will be found on areas of the body concealed by clothing, so they may be missed without a thorough examination. Immersion burns require evaluation by the involved health professional to determine whether they are accidental or resulted from abuse. For example, symmetrical burns without splash marks should arouse suspicion because accidental burns are not symmetrical and are most frequently accompanied by splash marks. Another indicator of abuse is head, facial, and mouth trauma. A study done in Minnesota found that approximately 65% of trauma from family violence is directed at the head and neck. Children frequently sustain accidental injury resulting in one black eye, but bilateral black eyes should be evaluated further. Similarly, large bald spots or broken hairs should be cause for further investigation. Subdural hematoma is always a reason for further evaluation. Dentists, dental hygienists, and dental assistants are in a prime position to detect and assess injuries to the oral facial region, such as loose or broken teeth. A torn labial frenum in a child who is unable to walk needs to be assessed to determine if the injury resulted from abuse or an accidental fall. Burns, scars, and substantial tissue sloughing inside the mouth may be the result of forced feeding of foods that are too hot. A key tool in detecting and documenting non-accidental dental injuries is the radiograph, something that dentists routinely use in their practice. Radiographs can provide solid evidence of fracture of the jaw or alveolar bone, tooth, or roots. The next indication of physical abuse is fractures. In the case of fractures, the history of injury is crucial in determining whether abuse has occurred. For example, spiral fractures are caused by a twisting motion. A report from a child's caretaker that the spiral fracture occurred when the child ran into a table, causing a lamp to fall on her arm, should result in suspicion. Children who have suspicious fractures should have x-rays taken to determine if there is evidence of other fractures, especially other recent fractures in various stages of healing. This may indicate a pattern of abuse. Denial of critical care. The next type of child abuse to be discussed is denial of critical care. This is the most frequently reported category of child abuse. Denial of critical care is the failure on the part of a person responsible for the care of a child to provide adequate food, shelter, clothing, or other care necessary for the child's health and welfare when able to do so, or when offered financial or other reasonable means. A parent or guardian legitimately practicing religious beliefs who does not provide specified medical treatment for a child shall not be considered to be abusing the child. However, this provision does not preclude a court from ordering that medical services be provided to the child when the child's health requires it. It is easy to miss symptoms of neglect because individual indicators may be less significant than an overall pattern. Children who are being neglected may be denied medical treatment by their caregivers, except in cases of emergency, and caregivers may shop around among doctors and hospitals, making it difficult for health professionals to assess the importance of any one indicator. If several indicators exist or symptoms reappear frequently, suspicion of denial of critical care should be high. These are some common indicators. The first is a lack of food, clothing, or shelter. Not providing children with these essentials is denial critical care only if the parents have the means to do so and choose not to. Parents or caregivers who do not have the ability to meet their children's needs are not the intended targets of the child abuse legislation, although other types of interventions may be appropriate in such cases as extreme poverty. A second factor in assessing for denial critical care based on lack of food, clothing, or shelter is one of common sense. While a mandatory reporter might well decide to report the case of a kindergartner who routinely walks to school in severe weather without a hat or gloves, that same person would be much less likely to report a similar situation in a 14-year-old who presumably has more ability to make decisions about how to dress. The second category is lack of adequate supervision leading to injuries. Caregivers must provide sufficient supervision to ensure the well-being of their children. Indicators of inadequate supervision might include such things as frequent injuries, a history of ingestion of harmful substances, or inadequate child care. The next category is medical noncompliance, which includes delaying or not seeking medical treatment or not following medical treatment plans. Medical noncompliance becomes denial critical care when the child's life or health is jeopardized by the caretaker's failure to act. Reporting abuse is not an appropriate tool to use when the parent and treatment team have legitimate difference of opinion about which of several methods should be selected to deal with a medical problem. For example, a parent who refuses a trial of stimulant medication in favor of impulse control training is exercising a parent's right to make medical decisions on behalf of a minor. However, a parent who neglects to regularly give insulin to a diabetic child needs to be reported for suspected medical neglect. Dental neglect is one of the most underdiagnosed forms of child maltreatment. According to the American Academy of Pediatric Dentistry, dental neglect is defined as the failure of a parent or guardian to obtain appropriate treatment for caries, oral infections, or any other condition of the teeth and supportive structures. As a result of such neglect, routine eating may become difficult or impossible. The child may have chronic oral pain, there may be delays in the child's growth or development, or the condition may make it difficult for the child to perform activities of daily living, such as playing, working, or going to school. The following three criteria must be met in order for a dental condition to be considered reportable neglect. 1. The presence of significant disease. The child must have pain, infection, or dental disease that, in the dentist's opinion, will result in pain and/or infection within the next 6 to 12 months if left untreated. 2. Parental awareness. The parent or legal guardian of the child must be informed and made aware that a serious dental condition exists that requires prompt treatment. 3. Financial resources. The parent or legal guardian must have the financial resources to pay for treatment and have transportation to get the child to the dentist. If the parent clearly understands that the dental problems need to be treated and financial and transportation arrangements are made and the parent or guardian does not obtain the dental care, reporting denial critical care should be considered. The last category of denial critical care is failure to thrive without physiological cause. Children who are victims of this type of neglect typically flourish when removed from the home and lose ground when placed back in the home. This slide shows a child diagnosed with psychosocial failure to thrive. This slide shows the same child following treatment. Sexual abuse. The next two categories relate to sexual abuse. Sexual abuse is defined as the commission of a sexual offense with or to a child as a result of the acts or omissions of the person responsible for the care of the child. A second category of sexual abuse is prostitution, which is defined as the acts or omissions of a person responsible for the care of a child which allow, permit, or encourage the child to engage in prostitution. In 1997, the Iowa legislature modified this definition by removing the necessity that the perpetrator had to be responsible for the care of the child in order for the criteria for sexual abuse to be met if the child in question is age 11 or younger. Unlike instances of physical abuse, most cases of child sexual abuse have no demonstrable medical evidence. Instead, the validation of abuse has its foundation in what the child says and, in some instances, how the child behaves. Either a positive or a negative medical evaluation may be consistent with child sexual abuse. In the cases where medical indicators are present, the following are among the most common: bruises, sexually transmitted disease, genital or anal injury, vaginal, penile, or urethral discharge, pain with urination or defecation, enuresis, or encopresis. Dentists may be in a key position to detect certain injuries caused by sexual abuse. A victim forced into an act of oral sex may have bruises to the hard or soft palate. Suspicious infections and lesions should be tested for disease of sexual origin. Bite marks can accompany sexual abuse. These marks should be measured and investigated. The canines tend to leave the deepest mark. Bites with an intercanine distance of more than 3 centimeters most likely were inflicted by an adult. While there is no core group of symptoms or behaviors that will be seen in all sexually abused children, a majority do manifest symptoms at the time the abuse is discovered. Evaluating behavioral symptoms is especially important in younger children because they are less able to recognize abuse and communicate verbally about it. Also, research has established a more reliable link between specific behaviors and a history of sexual abuse in younger children than in older children and adolescents. For example, a recent study conducted by William Friedrich found that typical young children exhibit a wide variety of sexual behaviors. However, certain behaviors observed in young children with a documented history of sexual abuse were rare in young children who had not been abused. These behaviors fell into 2 categories. First is sexual aggression to peers or adults. For example, a young child forces another to disrobe and fondle the child's genitals. Second are behaviors that are explicitly imitative of adult sexual activity. An example would be children imitating intercourse or soliciting sex acts from another person. In addition, some young children who have been sexually abused demonstrate generically sexualized behavior. That is, they have inappropriate sexualized play with toys or sexualized approaches to others at a developmentally inappropriate level. Clinicians who work with older sexually abused children and adolescents have noted that the following behaviors are common in this population: running away from home, suicide gestures or attempts, sexual promiscuity, or a total lack of appropriate sexual interest, substance abuse, anxiety, and depression. Obviously, these indicators are much less predictive than the behaviors discussed in connection with younger children, but they occur with enough frequency that mandatory reporters should be aware of them. Mental injury. Mental injury is defined as an injury to a child's intellectual or psychological capacity as evidenced by an observable and substantial impairment in the child's ability to function within the child's normal range of performance and behavior as a result of the acts or omissions of the person responsible for the care of the child. The impairment must be diagnosed and confirmed by a licensed physician or mental health professional. An example of mental injury is the case of a parent who handled her disapproval of her 7-year-old's bedwetting by wrapping a sheet around his neck, putting a sign on his back labeling him a baby, and putting him on the school bus. His refusal to speak for the next 2 months was a result of the trauma he suffered, according to a psychiatrist. Presence of an illegal drug. The presence of an illegal drug in the child's body as a direct and foreseeable result of the acts or omissions of the caretaker. If a health practitioner discovers in the child physical or behavioral symptoms of the effects of the exposure to cocaine, heroin, amphetamine, methamphetamine, or other illegal drugs, or combinations or derivatives thereof, which were not prescribed by a health practitioner, or if the health practitioner has determined that the child was exposed in utero, the health practitioner may perform or cause to be performed a medically relevant test on the child. The practitioner shall report any positive results of such a test on the child to the Department of Human Services. A positive test shall not be used for criminal prosecution of a parent for acts and omissions resulting in the intrauterine exposure of the child to an illegal drug. Bestiality. Bestiality is defined as a performance or attempt to perform, or coercion or attempt to coerce another person to perform or attempt to perform a sex act with an animal in the presence of a minor by a person who resides in a home with a child as a result of the acts or omissions of a person responsible for the care of the child. Manufacture, possession of dangerous substance. This type of abuse occurs when the person responsible for the care of a child has, in the presence of the child, manufactured a dangerous substance, knowingly allowed such manufacture by another person in the presence of a child, or in the presence of the child possesses a product containing amphetamine, its salts, isomers, or salts of its isomers, methamphetamine, its salts, isomers, or salts of its isomers, a chemical or combination of chemicals that poses a reasonable risk of causing an explosion, fire, or other danger to the life or health of persons who are in the vicinity while the chemical or combination of chemicals is used or is intended to be used in the process of manufacturing an illegal or controlled substance, or as a precursor or an intermediary in the manufacture of an illegal or controlled substance.
Allows access by a registered sex offender. This type of abuse occurs when a caretaker knowingly allows unsupervised access to a child by a registered sex offender to have custody or control of a child up to age 14 or a child up to age 18 if the child has a mental or physical disability. The exceptions are if the registered sex offender is the caretaker's spouse or is a minor child of the caretaker. Note, DHS must report this type of allegation to law enforcement, as this is a criminal act under child endangerment. Allows access to obscene material. This type of abuse occurs when a caretaker knowingly allows a child access to obscene material, exhibiting obscene material to a child, or dissemination of obscene material to a child, as defined by Iowa Code Section 728.1. In summary, Iowa law defines 10 different types of abuse to children. These types are physical abuse, denial of critical care or neglect, sexual abuse, prostitution, mental injury, presence of an illegal drug, bestiality, manufacture or possession of a dangerous substance, allows access by registered sex offender, allows access to obscene material.
Removal of a child. The Iowa Code 232.79 allows children to be removed from their homes and placed in protective custody without a court order when there's imminent danger to the child's life or health and there's not enough time to apply for a court order. A peace officer, a juvenile court officer, or a treating physician are the only professionals authorized to take this step without parental permission or a court order. When a physician authorized keeping a child in custody, attempts must be made to notify the parents, and oral and written reports must be made to the court in accordance with the law. Consult your institution's policies and procedures or the Department of Human Services for assistance.
At this time, and periodically throughout the remainder of the presentation, case scenarios are presented to illustrate the important points for mandatory reporters. Following each, you will be asked to determine if reporting of abuse or neglect would be mandatory in the situation described.
Your son has a concussion, some internal injuries, and a broken leg. Can you tell me how this happened?
He climbed up on the roof and jumped off. He's been talking crazy all day. He said he could fly, that he had special powers, and other stuff like that. He talks like this a lot, but he doesn't usually do anything. He just talks.
According to his records, he was diagnosed with bipolar affective disorder 2 years ago when he was 13. His psychiatrist recommended medication to control the symptoms. His hospital record indicates that when he was hospitalized, the medication was very effective at controlling his symptoms and the feelings of grandiosity, which almost totally disappeared. Is he getting the medication as prescribed?
Most of the time he gets it I don't really agree that he has a diagnosis or that he needs the medicine. I think he's acting out. He can control this if he wants to, and it's not easy to get to the store to pick it up either. It's a lot of bother just to hand the kid another crutch.
Can you tell me when the last time was that Chris got his medication as prescribed by the doctors?
It's been a while, I guess.
A couple of days, a week, a month, longer? Or has Chris ever really gotten into a routine with his medication at home? It's really important in helping Chris to have this information.
I can't really tell you. I let Chris be in charge of his own medication. I think he did it right on schedule for the first 2 or 3 weeks after he was discharged from the hospital.
Then what happened?
Well, the medicine from the hospital got used up. Chris told me about it, but it was several days before I got to the drugstore to refill the prescription.
Well, let me see what you understand about the medication, what it's for, and how to get it. Has somebody explained bipolar affective disorder to you? What his impact is on Chris's mood, his ability to think, and his ability to reason?
Yes, the people at the hospital, they explained to me, they gave me some reading material. They explained to me that Chris had a mood disorder and that affected his brain, and that the medicine would help control this, and that this could be really dangerous. If he felt too low, he could hurt himself, and then if he felt really high, he could hurt himself as well. And they said that he may have to be on this medicine for the rest of his life to be safe.
Well, it sounds like you have a pretty good understanding of Chris's diagnosis. Did anybody talk to you about how to purchase the medication? I know it can be expensive.
You can say that again. 1 month's supply costs more than our grocery bill, but luckily Chris has Title 19 and it takes care of that, so that really hasn't been a problem.
Well, you seem to understand the diagnosis, and you seem to also understand that the doctors feel it's important that Chris gets his medication, and the medication is covered by insurance. Can you help me understand why Chris is not getting the medication regularly? It seems very likely that what happened to Chris today is a direct result because he didn't take his medication. He could easily have been killed today. As it was, he was seriously injured.
I know that I should have gotten the medication. It just never came to the top of the list of all the things that I have to do. Working, driving the kids, places, all the other stuff. It just didn't seem very important. I know the doctor says that Chris can't always control his behavior when his mood is out of control, but I really expect him to do that. I think the doctor is making excuses for Chris, and besides, I think that parents have the right to make the decision about whether their kids take medicine or not. If I ever get really convinced, I guess I'll see that he takes it.
Well, Chris is going to need to be admitted to the hospital today because of the injuries that he suffered. When he goes home, he's going to need to take his medication exactly as the doctors have prescribed it. He's also going to need special attention and have some specific instructions to follow because of the injuries he sustained today. I'm not sure if I can count on you to follow through with the recommendations. What do you think?
Can we talk about this later? I just want to see Chris.
I have some real concerns about how poorly Chris's treatment recommendations have been followed. If Chris had been taking his medications, it seems very unlikely that this incident would have occurred. Is the parent's non-compliance with treatment recommendations child abuse?
As a mandatory reporter, the physician should report suspected child abuse due to noncompliance with the treatment plan. The physician determined that the parent understood the diagnosis, what the medication was for, and had the means to obtain the medication. The failure to follow treatment recommendations was serious enough that it put the child's life and health in danger.
Finished examining Laura now, and she expressed some concerns that I'd like to talk to you about. She gave her permission for me to talk to you, and I encouraged her to be here when we spoke, but she'd prefer to wait in the waiting room.
Okay.
She mentioned that she's been experiencing some vomiting recently, and also that she's been more tired than usual. Have you noticed these symptoms?
Well, the vomiting, I'm not aware of that, but she has her own bathroom, and I have to admit I don't always know what goes on in there,
Sure.
but she practically has lived in the room since we remodeled it for her a few months ago. Having an extra bathroom has really been helpful to keeping peace in the family.
I can imagine.
Laura. The tiredness, well, now that you mention it, she has seemed to be less active the last couple of weeks, just kind of sitting around and moping. She's even gone to bed a couple of times without being asked. Her friend has mono. Could she have that, perhaps?
Well, Laura wondered about that too, and she also had some other thoughts about explanations for her symptoms.
Okay.
But after we'd spoken for a few minutes, she burst into tears and wondered whether her symptoms could be related to pregnancy.
Pregnancy? Oh, she can't be pregnant. She's only 11. She's just a kid.
I'm sure this is quite a shock for you.
Yes, I mean she's never had a date. She barely even has had any periods. I think there's got to be another explanation for this.
Well, she was reluctant to talk about this, but she did say that she's had intercourse 3 times.
3 times? Oh my God, she doesn't even have a boyfriend, at least not one that I'm aware of anyway. Who's the boy? I mean, where did they have sex? I can't believe that.
Said that this is a boy that she met at her gymnastics club, that he's a sophomore in high school.
Sophomore?
And that initially they had a friendly relationship, that they used to run together during warm-ups and warm-downs at gymnastics practices. It sounds as though things changed when they went to a gymnastics meet in St. Louis a few weeks ago.
Oh my God. So is that where it happened then?
It sounds as though that's where it happened, that she visited him in his hotel room, but once the activity started, she didn't want to say no. She was afraid that she would be considered to be a baby.
Oh, I can't believe this. I can't believe she didn't say anything to me. He must have raped her. I can't believe that she would willingly agree to have sex with him. She's just not that kind of girl. She just wouldn't. She's just a baby.
I think you're right in that regard. I don't think she was physically forced, but I don't think that she felt that she could say no. I think that she really didn't plan to have this type of activity, but that she was afraid to say no when she realized what was happening.
Oh, where were the chaperones? I just can't believe this happened to her. Oh my God. I mean, this is unbelievable. I mean, what can we do about this? I can't believe she didn't tell me. What can I say to her? I mean, and what can we do about this boy? I mean, after all, he's a sophomore. She is just a child. Isn't this child abuse?
This is reportable as suspected child sexual abuse because the law requires that all cases of suspected sexual abuse be reported to the Department of Human Services if the child in question is age 11 or younger, regardless of whether the suspected perpetrator is a caregiver. For children who are age 12 or older, suspected sexual abuse by a non-caretaker can be reported, but does not have to be.
I understand that you're here mostly today to get a routine physical and to bring Shannon's shots up to date. Is that correct?
Yes, that's right.
The nurse did tell me that you have some other concerns as well about an injury that Shannon has. Maybe you and I could talk about that while Shannon is in with the nurse.
Well, Shannon was outside playing recently, and she happened to go into a neighbor's yard. I think she was following a cat that wandered by the house. She really loves animals, especially cats. Anyway, she ended up in this yard a few houses down the block. And it was a gentleman that we don't really know, we haven't had much contact with, and we haven't had any trouble with him. Anyway, Shannon said that he came out of the house and started yelling at her to get out of his yard. She tried to explain to him that she was after the cat, but he became very impatient and came after her.
What happened next?
Shannon says that he picked up a fly swatter and chased her with it, even though she was clearly headed off his property.
Was he trying to scare her, or did he really mean to hit her?
I think he meant business. He got her twice on the back, pretty hard too. She came home crying so hard that it was hard for me to calm her down enough to find out what had happened. When I looked at her back, there were red marks where she had been hit. By the next day, there were clear bruises. You can still see the marks today.
Did you all talk to him, ask him what he was thinking?
My husband and I both went down to talk to him. He didn't deny what had happened at all. In fact, he showed us the fly swatter. He said he doesn't want kids on his property, and if they come on, he'll get them off whatever way he chooses. We told him that if he just asked Shannon nicely to leave, she would have done so. It wasn't necessary to hit her.
This must have been very upsetting for Shannon. How is she handling it? Do you need any help with this?
No, she's actually doing okay. She's certainly not going to go anywhere near his house again. We just think that he shouldn't get away with what happened. There are other children in our neighborhood. They come and go as they please. It's always been a situation where the other parents look out for the other children, protect them, and keep the neighborhood safe.
So what are you thinking about doing?
We wonder if it's not a case of child abuse. He hit her and he left a bruise. It certainly wasn't an accident. We're wondering if this is a case where it would be appropriate to file child abuse charges.
It looks like you're going to be okay. I do want to ask you about the marks on your back. I found some bruises there that look pretty recent. Can you tell me how you got them?
That happened yesterday. A man who lives on our street hit me with a fly swatter.
Hit you with a fly swatter? What was going on?
It was really strange. I followed a cat to see if it was the same one that was being advertised as lost. When I got there, he came running out of his house, yelling at me to get out of his yard.
Did you tell him what you were doing there? About the cat?
I started to, but he wouldn't let me finish. He started chasing after me and swinging the fly swatter. I tried to get to the front gate to leave, but I didn't make it. He caught up with me and just started hitting. He was yelling and hitting. I started crying even before I got hit. And when he hit me, I screamed. I wasn't even in his yard anymore. When I got hit, I was on the sidewalk trying to get away from him. He seemed like a madman. I was really scared.
Do you know if he has been after kids like that?
Not that I know of. My mom told me to stay away from there. Like she would need to tell me that. I'm never going near his house again. And I'm going to tell my friends to stay away too.
I'm sorry that happened to you, Shannon. That wasn't a nice way to end your summer. What would you like to see done about this? I'd like your opinion before I talk to your mom.
I don't know. I just don't want him to ever do anything like this again.
The social worker, as a mandatory reporter, would not file a suspected child abuse report because the interview with the mother and with the patient confirms the fact that the perpetrator is not a caretaker of the child. The social worker should inform the parent and the child of their options to talk to the police about assault and battery charges.
Please answer questions 1, 2, 3, and 4 now.
In an effort to provide lifespan protection from violence, the Iowa legislature in 1985 passed dependent adult abuse legislation. This law was patterned after protection offered children, but included additional protection based on the unique characteristics of this population. The dependent adult abuse law identifies 4 different types of abuse: physical abuse, sexual abuse, exploitation, denial of critical care deprivation. As with child abuse reporting, the mandatory reporting of dependent adult abuse also requires that 3 components be present before reporting of the abuse becomes mandatory. First, there must be a dependent adult. A dependent adult is defined as a person who is 18 years of age or older who is unable to protect his or her own interests or unable to adequately perform or obtain services necessary to meet essential human needs. The dependent adult requires assistance from another due to his or her physical or mental condition. The definition of dependent adult is less clear-cut than the definition of a child, so careful assessment must be made if suspected adult abuse victims may be dependent adults. Persons with severe dementia are considered dependent due to their mental condition. Persons who are confined to a wheelchair are considered to be dependent only if they are unable to adequately perform or obtain services necessary to meet their care needs. There are some exclusions to the dependent adult abuse reporting criteria that mandatory reporters need to be familiar with. Prisoners are not included in the dependent adult abuse legislation. Likewise, it is not considered to be abuse when care needs are not met when the caretaker lacks the means to do so. It should also be noted that domestic violence without the presence of a dependent adult is not covered under the mandatory reporting requirements. The second component that must be present is that the suspected perpetrator of the abuse must be a caretaker, with the exception of deprivation, in which no caretaker is involved. A caretaker is any related or unrelated person who has the responsibility for the protection, care, or custody of a dependent adult. People become caretakers as a result of assuming the responsibility voluntarily by contract, through employment, or by court order. An institution can be a caretaker. Third, something has to have happened that meets the criteria for at least one of the 4 types of dependent adult abuse. In many ways, the types of dependent adult abuse are similar to the types of abuse that were previously discussed related to children. There are, however, unique features of dependent adult abuse.
Physical abuse. Physical abuse is defined as a physical injury or an injury which is at variance with the history given of the injury, or unreasonable punishment, or assault as a result of the willful or negligent acts or omissions of the caretaker. The physical abuse indicators for dependent adults are similar to those discussed in the section on children, such as burns, bruises, welts, and fractures. There is one notable addition. Unreasonable confinement is considered to be a form of physical abuse. Unreasonable confinement includes the use of chemical or physical restraints to replace supervision. A caregiver who ties a person with advanced Alzheimer's into a wheelchair so that the caregiver can leave the home for a few hours is using unreasonable confinement as a substitute for appropriate supervision. Likewise, a group home staff member who triples the dose of an antipsychotic medication ordered by the client's physician with the goal of producing sedation to limit disruptive behavior, rather than employing the client's behavior management plan, is using unreasonable confinement through chemical restraint. As noted earlier, many of the guidelines used in assessing for physical abuse in children are useful in the assessment of dependent adults as well. However, there are some differences based on the unique characteristics of this population. It is not uncommon for older adults or others with certain types of medical problems to take medication which increases the risk of bruising, So determining medication history is an important part of assessing bruises as indicators of abuse. In addition, dependent adults who are older, as well as certain others with specific medical conditions, may be susceptible to fractures. Sexual abuse. The second type of dependent adult abuse is sexual abuse. This area is almost exactly the same as childhood sexual abuse. The definition of sexual abuse is the commission of a sexual offense with or against a dependent adult, which includes sexual abuse first, second, or third degree, detention in a brothel, indecent exposure, and assault with the intent to commit sexual abuse. What makes it sexual abuse is that the caretaker takes sexual advantage of the dependent adult. Dependent adults are by definition those who cannot take care of their own best interests and therefore are dependent on caretakers.
Denial of critical care deprivation. The third type of dependent adult abuse is denial of critical care deprivation, or neglect. This is defined as knowingly depriving a dependent adult of the minimum food, shelter, clothing, supervision, physical or mental health care, and other care necessary to maintain life or health when the caretaker has the means to provide them. Indicators that suggest neglect include dehydration or malnutrition due to lack of food or water, untreated skin breakdown, inappropriate clothing for the weather, missed follow-up appointments for necessary medical or psychiatric care, or failure on the part of the caregiver to refill needed prescriptions. Environmental threats to well-being may include lack of heat in winter, contaminated water, no access to essential rooms or exits of a dwelling, or dilapidated housing. It is not considered denial of critical care when the dependent adult's caretaker, acting in accordance with the dependent adult's stated or implied consent, declines medical treatment if the dependent adult holds a belief or is an adherent of a religion whose tenets call for reliance on spiritual means in place of medical treatment. Likewise, withholding or withdrawing health care from a dependent adult who is terminally ill when the withholding or withdrawing of health care is done at the request of the dependent adult or at the request of the next of kin or guardian and pursuant to applicable procedures in the Code. Chapters 125, 222, 229, or 633, is not considered to be denial of critical care. Exploitation. Exploitation of a dependent adult occurs when the caretaker takes unfair advantage of the dependent adult's physical or financial resources without his or her informed consent. It includes theft, the use of undue influence, harassment, duress, deception, false representation, or false pretenses. Financial abuse of dependent adults is an area that has been largely ignored, except in cases where there is considerable wealth. However, financial exploitation also occurs with persons with little income and few resources, with devastating effects on both physical and emotional health. There are multiple indicators of financial exploitation. One of these indicators is particularly relevant for healthcare providers. Financial exploitation occurs when the caretaker refuses to allow the patient's resources to be used for needed care. Other indicators include questionable signatures on checks or documents, recent changes in a will when competency is in question, excessive bank withdrawals or sudden changes in spending habits, unpaid bills, the disappearance of valuables, or transfers between accounts that the adult cannot explain. To summarize, there are 4 types of dependent adult abuse in the community. These 4 types closely model the child abuse components with a couple of unique variations. Physical abuse, sexual abuse, exploitation, denial of critical care, deprivation. Dependent adult abuse includes the following as a result of the willful misconduct or gross negligence or reckless acts or omissions of a caretaker, taking into account the totality of the circumstances. There are 5 categories of dependent adult abuse in health-related facility. These closely model community adult abuse components with a couple of unique variations. Physical abuse, sexual abuse, sexual exploitation by a caretaker, financial exploitation, neglect. Physical abuse. Physical injury, which is at variance with the history given of the injury, or unreasonable confinement, unreasonable punishment, or assault that involve the breach of skill, care, and learning ordinarily exercised by a caretaker in similar circumstances. Sexual abuse. The second category of abuse in a healthcare facility is the commission of a sexual offense with or against a dependent adult. This includes sexual abuse, detention in a brothel, indecent exposure, assault with intent to commit sexual abuse and incest, sexual exploitation by a counselor or therapist, invasion of privacy, nudity, or incest. Sexual exploitation by a caretaker. Consensual or non-consensual sexual conduct, including kissing, touching clothed or unclothed breast, groin, buttock, anus, or pubis, and or transmission, display, or taking of electronic images of unclothed breast, groin, buttock, anus, or pubis that is not related to treatment or diagnosis. This does not include touching that is part of the examination, treatment, or care by a caretaker acting within the scope of the practice or employment of the caretaker. The exchange of a brief touch or a hug for the purpose of reassurance, comfort, or casual friendship, or touching between spouse or domestic partner in an intimate relations. Financial exploitation. A caretaker knowingly obtains, uses, endeavors to obtain, to use, or who misappropriates a dependent's funds, assets, medications, or property with the intent to temporarily or permanently deprive a dependent adult of the use, benefit, or possession of the funds, assets, medications, or property for the benefits of someone other than the dependent adult. Neglect. Deprivation of the minimum food, shelter, clothing, supervision, physical or mental health care, or the care necessary to maintain a dependent adult's life or physical or mental health. This does not include the dependent adult declines medical treatment because the adult holds a belief or is an adherent of religion whose tenets and practices call for reliance on spiritual means in place of reliance on medical treatment. The dependent adult's caretaker declines medical treatment, acting in accordance with the dependent adult's stated or implied consent, or a dependent adult or the adult's next of kin or guardian requests withholding or withdrawing of health care from the adult who is terminally ill in the opinion of a licensed physician.
Good morning, Mrs. King. Hope we haven't kept you waiting too long.
No.
Any problems that you'd want us to be aware of today?
I don't think so. To be perfectly honest, if my neighbor hadn't come over and gotten me, picked me up this morning, I wouldn't have remembered I had this appointment.
So you forgot about us today, huh? That's understandable. That really happens quite a bit. That's why we have our receptionist call you yesterday to remind you of your appointment. Do you remember talking to her?
Oh dear, I'm afraid I don't. So many things have been happening to me. I just can't keep track of my life anymore.
I'm going to check your blood pressure now, okay? That's good. What are you having trouble keeping track of?
Well, things just don't seem to make sense. Even in my own house, I look around and things don't seem familiar to me. And I've lived in that house for over 30 years. But things just don't look right. I guess it's more that it doesn't feel right.
Are these new feelings? Have you talked to Dr. Lindell about these before?
No. I don't know how long I've been feeling this way. But I probably haven't mentioned it to anyone because I didn't want anyone to know. It makes me sound like I'm not all here.
I think you need to talk to Dr. Lindell about that today. He might have some good ideas. Let's go over and have a seat on the chair and wait for him over here. Mrs. King, just have a seat right here for me, okay? Dr. Lindell will be in shortly. Can I get you something to read while you wait?
No. I can't seem to concentrate to read anymore.
Okay.
Good morning, Mrs. King. I hope we didn't keep you waiting too long. We've really been swamped in the clinic this morning. So how have you been feeling? Any problems with that arm?
Well, a few, I guess. I can't seem to grip very well, and I keep dropping things. And I can't get my telephone to work at all. Last night I was boiling some water for tea, and when I went to pour the water in the cup, the teapot just slipped right out of my hand and I dropped it on the floor. That really worried me.
Did you get hurt or burned?
I don't think so. But so many things went wrong yesterday, I just can't keep track of them. When my neighbor called, I tried to think of anything pleasant that I could tell her that had happened, because I thought, if she really knew what was going on, she would worry. And that's my biggest worry, that people will think I can't manage for myself.
Well, it seems like your arm is not back to normal yet. And Kate was telling me you're having some difficulty with your memory and feeling comfortable at home. Are all of those things new for you, or have you been somewhat reluctant to talk about those in the past? Anything else going on that's worrying you?
Well, yes. Sometimes I'm just confused. And I keep falling asleep all the time. And then when I wake up, if the clock says 5 o'clock, I don't know how to tell if it's morning or night. I don't know whether I should get ready to go to bed or get up and get ready to go to church. And I can't seem to think what I'm supposed to be doing, even in my own house. I've always had Monday chores and Tuesday chores like that for over 30 years, the same schedule. But now, Monday comes, and I don't even think about it being Monday. I don't know what day it is and what I'm supposed to be doing. Sometimes a whole day goes by, and I don't know what I did.
That sounds really different. Nothing I've ever heard you say before. I've noticed, looking at the chart, you've also lost quite a bit of weight since you were here last. Looks like about 15 pounds. What's up with your eating? Has the problem with your arm made it difficult to fix meals?
That might be a problem if I cooked for myself, but I have Meals on Wheels at noon. The social worker got that for me when I had my arm surgery, but I don't always eat the lunches. It's kind of odd. I know I'm hungry, and I intend to eat the lunch, but then I just seem to forget about it. And later in the day, I'll find the box sitting somewhere in the house. I'm afraid to eat the food then because it might be spoiled. I must have 9 or 10 boxes of spoiled food sitting around right now. And I feel so bad about wasting all that lovely food. And the social worker was so nice to arrange that for me. I just wish I could get my life organized so I could do things the way I used to do them.
Does anyone come in on a regular basis to check on you? Or is there someone you could call if you needed help?
Oh my, no. Things may not be as good as they used to be, but I certainly don't want to get in the habit of having to rely on someone else just to get through the day. What would that say about me if I can't do things for myself? Oh no. Sometimes you just have to make do.
I can see you really value your independence. I can certainly understand that.
But to be honest, I have some real concerns about whether you're taking good enough care of yourself. It doesn't seem as if you're eating very well, even if you intend to. And I wonder if you're taking your medicines on a regular basis, because those are scheduled at meal times. You've already said you have some difficulty with using the telephone, so you must be pretty isolated right now. Also, there's no one to come in to check on you on a regular basis. I'm going to have Kate come back in the room and give you a flu shot. That's one thing we can do today to help keep you healthy. And when she's done, I'd like you to wait right here, and I'll come back in a few minutes to talk with you, okay? Beth, I think you're familiar with Lila King. She was in the hospital a couple of months ago with a fractured wrist. Do you remember her?
I remember her. She lives alone. No family, some acquaintances in the neighborhood, but no close friends. She'd been managing pretty well before the fall and the fracture. If I remember correctly, she agreed to Meals on Wheels, but wouldn't accept any other services. She was pretty firm in her refusal. We felt lucky that we got her to accept anything. She seems a lot like my mom. Doesn't want to admit she can't do everything for herself anymore. Is she having trouble? I happened to see her in the waiting room this morning.
I have some concerns about how she's doing. It's usually hard to get any complaints out of Lila. She always puts on a pretty happy face. But today, she talked about some things that make me concerned about confusion. She's certainly not eating well, and I'm not sure if the poor eating has led to the confusion or the other way around. I doubt she's getting her medicine, and her hygiene has declined. She's pretty isolated, and I'm not sure she could or would use the phone if she needed help. And I'm afraid a situation is likely to come up when she will need help.
Is she on the same wavelength that you are? That more help might be needed?
That's part of what I wanted to talk to you about. I brought up the idea of some additional help at home, but she got quite upset about the suggestion. Said pretty clearly that she is not interested. She seems to be afraid of what others might think, or perhaps try to do if they think she can't manage. I'm not sure that she'll agree, and I'm worried that she'll try to conceal her symptoms in the future. I'm not at all sure that she's safe at home.
I'll be happy to go talk to her. I can check on how the meals are working out and then see how receptive she might be to some additional help. I'll frame it from the perspective of services her tax dollars have provided to keep folks independent in their own homes. I can do that now and give you a page when we're done visiting, if that's okay.
Great. If she won't agree, is there something else we can do? If someone else were living with her, we would describe Lila as being neglected and report the caretaker. But since no one is living with her or taking care of her, is it possible to report a person for self-neglect? Would that get someone to take a look at what she needs?
This is reportable as self-abuse, as this patient is not able to provide for her own needs at this time and requires a caretaker but does not have one.
Mrs. Minnow is a 46-year-old computer programmer who lives in Cedar Rapids. She was admitted for workup of persistent abdominal pain. She has had a previous admission at this hospital before for bipolar affective disorder. Let's see, that was about 3 years ago. And at that time, she had severe psychotic symptoms and was actually brought to the hospital by a coworker who observed her bizarre behavior at work.
This case sounds familiar to me. Did social services get involved during the last admission?
It looks like suspected dependent adult abuse charges were filed during the previous admission. Mrs. Winnow's adult son was living with her at the time. She seemed to become really irresponsible about money, deciding that giving everything that she had away to other people would make her happy as well as everyone else. During this time, her son talked to her about buying him a new car and thousands of dollars worth of other items. All this while, she was not paying her mortgage and almost lost her home and did lose her car.
I remember this case now. We decided that her symptoms were so severe that she could not make rational decisions. Her son certainly knew that, and he took advantage of her.
Well, the bipolar disorder seems to have responded well to medication. She says she's doing well at work and that her mood is stable as long as she's taking her medication. And she seems to be responsible about taking it. And there doesn't seem to be any current psychiatric complaints with her. But the same son is back in the picture. I saw him in the room last night, and she was writing him a check. He seemed angry and demanding about it, and he needed the money right away to make a payment. She gave it to him, but I could tell she didn't want to.
Well, it's not really like what he did last time, but he is still taking her money. We're about ready to discharge her. Do we need to file dependent adult abuse charges before she goes? He is taking advantage of her again.
This is not reportable dependent adult abuse because Mrs. Winnow does not meet the criteria for a dependent adult at this time, though she clearly was a dependent adult when her bipolar disorder was untreated.
Hi, I'm the physician taking care of your mom, and we've just finished examining her, and I understand she came from a nursing home?
Yeah, that's right. The nursing staff say that she winces every time we touch her stomach. She hasn't been eating very much either, and that's unusual for her. Mom's not able to talk and tell us what's going on, at least not so that it makes sense.
Well, we're going to run some tests here in a few minutes, which should give us some answers. I see that we saw her about a month ago, and at that time, was she living in the nursing home, and how long has that been?
Yeah, she's been there about 4 years. She went in when she turned 83. She seemed to do really well at first, but has seemed to go downhill since then. She broke her hip, and then she wasn't able to walk, and now she's in the wheelchair most of the time. She's not able to get up to go to the bathroom, so she's often wet. I think that really annoys the staff.
When she was in the clinic about a month ago, we noticed a red spot that was on her buttocks, and we alerted the floor at the nursing home that they needed to do some careful skin care.
Yes, I remember that. We discussed those concerns at Mom's last care conference about 2 weeks ago. They developed a plan for shifting her and positioning her. But to be honest, I just don't think they have the staff to do what they say they're going to do.
What do you mean by that?
There's so many people to take care of there at the nursing home. She's supposed to be checked and changed right after lunch, but that never gets done until the nurses come on at 3 o'clock. She doesn't get moved from her wheelchair until then either. I've mentioned this to the staff as a concern, but they just tell me they're doing the best that they can.
Well, she has some pretty significant breakdown on her skin. It's what we call a decubitus ulcer. And if it isn't treated correctly, it could become quite serious. It's probably quite painful right now, but your mother just can't let us know that.
So what do you think can be done to help her?
I think we can do a couple of things. We'll start treatment while she's here and send some instructions back to the nursing home. And also, since she's somebody who can't take care of herself and is under the care of the nursing home, I think I'm going to talk to our social worker about some other steps that we can do. Well, hi, Margaret. I wanted to talk to you about Mrs. Butler that I saw in room 62. She's in today for some abdominal pain, but has a pretty serious decubitus ulcer on her buttocks. We noticed some initial skin irritation when she was in the clinic last month and called it to the attention of the people at the nursing home. Her daughter said that they did develop a plan with it. Is it worse today? Well, Mrs. Butler really can't give us a very good history, but her daughter says that they don't position her or change her quite as frequently as we were recommending. I doubt that they intended to be neglectful of her, but I have some concerns. I've had other patients there who have gotten good care, but I just wanted to know what you thought, whether this was dependent adult abuse or not. I'm just not real comfortable with that part of my job.
The physician would need to file suspected dependent adult based on the criteria for denial of critical care. Institutions, including hospitals, nursing homes, and licensed daycare centers, are defined in the law as caregivers. Mrs. Butler's decubitus ulcer appears to have resulted from improper handling of her incontinence and improper handling of her inability to move about independently.
We've just reviewed all of the laws regarding child and dependent adult abuse and some of the physical indicators. In a healthcare setting, recognition of abuse involves more than this. Professional recognition of factors or situations that indicate that abuse may have occurred is an important aspect of the detection of abuse. There are several ways that healthcare professionals might become concerned about the possibility of abuse. Healthcare practitioners, in their contacts with children and dependent adults and their caregivers may become aware of personal or environmental situations or conditions that may increase the likelihood that behavior which is considered abusive may occur. These situations are related to caregivers and to victims. The presence of any of these characteristics is by no means proof of abuse, but should cause healthcare practitioners to assess the situation further. There are several signs to look for in the behavior of the caretaker or the parent. The first indicator is inconsistency in the description of the problem or the injury. For example, a 3-year-old presents in the emergency room with stocking burns. The caretaker reports that the child accidentally climbed into the bathtub when the water was too hot. The incident, as described, does not match the history given by the caretaker. It's unlikely that a child would accidentally sustain identical, symmetrical burn marks to both legs. The professional may appropriately suspect that the child was held in scalding water. The second indicator is doctor or hospital shopping. Caretakers may avoid returning the child or dependent adult to the same practitioner. If you're concerned about the possibility of abuse, it's important to get a thorough and detailed history identifying all healthcare providers. The third indicator relates to caregiver situations. The presence of any of these characteristics is not in and of itself proof that abuse has occurred, but indicates the need for further assessment. 6 factors relate to caregivers. The first is substance abuse in the caregiver. Persons abusing drugs or alcohol are compromised in their ability to meet the demands of children and dependent adults. The second is unemployment or poverty. Not being able to meet a family's basic needs because of insufficient resources results in stress and anxiety that may interfere with caretaking responsibilities. The third is isolation from meaningful relationships. Providing care for children or dependent adults becomes much more challenging when the caregiver does not have friends or relatives around to provide advice, support, or respite. The fourth is domestic discord. When adults are violent with each other, children and dependent adults are often victimized as well. In addition, children may learn to use violence as a method for handling conflict. The fifth is history of childhood abuse. Adults who are abused as children may treat their own children or those dependent on them the same way without thinking of it as abuse. The sixth factor concerns caregiver traits that interfere with the ability to nurture dependence. One example would be psychiatric disorders that may affect the perception of reality or the ability to empathize with others. Another example would be personality characteristics such as frustration tolerance or temper control. Now that we've looked at the factors relating to caregiver situations, let's turn to the indicators relating to victim situations. There are certain characteristics in children and dependent adults that increase the likelihood that abuse will occur. It's very important to emphasize that this does not mean that victims are responsible for their abuse. First, persons with physical or mental handicaps or chronic illness may present special challenges to their caregivers. Caregivers who are unable to adequately meet these special challenges may become frustrated, resulting in an increase in the likelihood that abuse may occur. The second factor relates to problems that children may experience in infancy. Prematurity, low birth weight, or chronic problems in early infancy interfere with parents' ability to feel competent in meeting the needs of the child. Third, some children and dependent adults present special challenges due to their temperament or behavioral characteristics. Children and dependent adults who are irritable, who have trouble adapting, who are aggressive or defiant, or who are unable to relate to others require extra patience from their caregivers. Dependent adults become increasingly vulnerable to abuse as they become more dependent, as communication skills decrease, or as they become socially or physically isolated. We've just covered the professional recognition of child and dependent adult abuse. Once you've recognized and suspected that abuse has occurred, it's important to understand the reporting protocols. The remainder of the presentation will address issues related to reporting, including liability issues, the classes of reporters, and documentation requirements.
There are two classes of reporters. Mandatory reporters must report suspected abuse, while permissive reporters may report suspected abuse. The Iowa Code states, every health practitioner who examines, attends, or treats a child or dependent adult, and who reasonably believes the child or dependent adult has been abused, is a mandatory reporter. The legal obligation to report is limited to situations in which the health care practitioner is examining, attending, or treating the child or dependent adult. Mandatory reporters must make reports. Permissive reporters are not legally obligated to make reports, but they may make reports. For example, a physician who witnesses a caretaker slapping a patient in his or her waiting room and notes an injury during the appointment must report. A physician who witnesses the same sort of incident in the grocery store is a permissive reporter. There are no legal consequences for a permissive reporter's failure to report, but it is suggested that there is a general moral responsibility to do so. The Iowa Code provides protection from criminal and civil liability for persons who are reporting abuse in good faith. The Code states, a person participating in good faith in the making of a report, or photographs, or x-rays, shall have immunity from any liability, civil or criminal. Similarly, mandatory reporters are protected by law from any form of retaliation by their supervisors or employers for turning in an abuse report. The Iowa Code states, it shall be unlawful for any person or employer to discharge, suspend, or otherwise discipline a person required to report or voluntarily reporting an incident of suspected child abuse or dependent adult abuse. A person or employer found in violation of this law shall, upon conviction, be guilty of a simple misdemeanor. Mandatory reporters continue to be legally obligated to report, regardless of what the other team members indicate. On the other hand, a mandatory reporter who knowingly fails to report suspected child or dependent adult abuse is personally liable for any damages caused by the failure to report, including any criminal or civil liability. For example, in Colorado, a divorced woman took her child to a local physician. The boy had obviously been abused, but the physician did not report the abuse. The mother subsequently murdered her son, and the boy's father sued the physician for not reporting the abuse. The father won, and the physician was ordered to pay $14 million in damages. Even though Iowa law provides legal protection for mandatory reporters, making a report often engenders many feelings. For example, mandatory reporters may feel uncomfortable in making a report because society in general is hesitant to intervene in the lives of others without being asked. Similarly, mandatory reporters may feel frustrated when they make a report and the situation seems to remain unresolved. Finally, mandatory reporters may be concerned about altering the treatment relationship due to possible hostility or anger from the alleged perpetrator. While these feelings are common and understandable, they do not alter the mandatory reporter's responsibility to report suspected cases of abuse.
Mrs. Kelly, I think we're through with you for today. Let me just check to make sure that we've done everything we need to do before you go. You've had your blood drawn, you've been to the x-ray, you've seen the doctor, he's talked with you about his findings and his recommendations. I'd like you to stop at the desk and schedule an appointment for yourself in 6 months. Do you have any questions for me before you go?
Well, there is something that's really bothering me.
I don't know if this is the place to bring it up or not. I don't even know if it's any of my business, but
I'm here to listen to any concerns that you may have. If I don't have the answers, I'll find someone who does. Something really seems to be bothering you.
I live in this apartment building, and this new girl moved in across the hall, and she has a little baby. She looks like a kid herself, and the baby can't be over 6 weeks old. And she's gone a lot. And I kept hearing this baby crying and crying. And I thought, well, maybe the babysitter's not doing her job. But the other day, I heard all this yelling out in the hallway. And this woman, I'm thinking it was probably the grandmother, said, I don't care what, you can't go off and leave that baby alone. And then about 10 minutes later, after the mother's left, I hear the young girl go out. And then I hear this baby screaming and screaming. And I'm sure she was in there by herself. What happened if there'd be a fire, or the baby got sick, or she just needed to eat or have her diaper changed? I mean, that's no way to treat a baby. I just don't know what to do. If I say anything to the mom, she probably won't listen to me. She didn't listen to her own mother. And I'm afraid she'll get mad at me, and I live there in the apartment by myself. Isn't this child abuse?
This is not an instance where mandatory reporters must report, because the child in question is not being treated by the mandatory reporter. The mandatory reporter might instruct the patient how to report her concerns to DHS, or might decide to report as a permissive reporter.
Please answer questions 5, 6, 7, and 8 now. The next area that the mandatory reporter needs to be familiar with is documentation. Documentation is often a pivotal factor in supporting an abuse allegation. Therefore, timely, accurate, and complete documentation of observations, statements, and the chronology of events is important. Adequate documentation is an interdisciplinary responsibility. Although most abuse cases do not go to court, when there is court involvement, the protective service system relies heavily on medical record documentation. It may serve to establish the patterns of behavior needed to determine many types of neglect or denial of critical care. Documentation requires that all involved personnel record their observations and conversations with suspected abuse victims, caretakers, and other concerned individuals. There are some common tips to remember when making an abuse report. These include: record the content of interviews. Clearly distinguish the statements made by the interviewers from those made by the interviewees. Identify all sources of information. Use direct quotes whenever possible. Clarify specific terms used to describe relationships. The person a child refers to as daddy may not actually be the child's father, but instead may be a stepfather, uncle, or the mother's boyfriend. Clearly note discrepancies in information provided by all who are interviewed. Professional opinions or impressions should be documented, but must be identified as opinion rather than presented as fact. After there is reason to believe that abuse has occurred, after documentation has been completed, and after a decision has been made to file an abuse report, the next step is following your organization's established reporting procedures. The following procedures shall be carried out when the decision to report the patient as an abused child or dependent adult has been reached.
There are 3 steps in completing a report. The first step is the oral report. The mandatory reporter or your institution's designee will call the Department of Human Services within 24 hours of establishing suspicion of abuse of children or dependent adults in the community. The number is 1-800-362-2178. When reporting a dependent adult when the suspected abuse occurred in a health-related facility, contact the Department of Inspections and Appeals, or DIA, at 877-686-0027. The second step involves completing and delivering the written report. The mandatory reporter will complete and sign your organization's mandatory child and dependent adult abuse report. A copy of this report should be placed in the patient's medical record, and the original should be forwarded to the appropriate Department of Human Services office. At UIHC, this form is the B-22A form. It is an electronic document and should be completed by the mandatory reporter. Once completed, it electronically goes to the UIHC Department of Social Service. The UIHC Department of Social Service will forward the written report to the Iowa Department of Human Services. When you are listed as the first mandatory reporter on the form, DHS will notify you in writing about their decision to accept or reject the report, and will also notify you to the results of their assessment. Please forward these written notifications to the Department of Social Service. The UIHC Department of Social Service will track the outcome of the report and place the outcome information in the patient's medical record. If a report needs to be made after 5 p.m. and before 8 a.m. or on weekends and holidays, the mandatory reporter may call the 800 number or may contact the social worker for assistance by calling the hospital operator. The final step is notification. The appropriate parent, legal guardian, or caretaker should be advised by the mandatory reporter of the decision to report. Face-to-face notification is the optimal method of communication. If face-to-face is not possible, then notify via telephone, or, if that is not successful, by registered mail. Document all contacts or attempts to contact. On occasion, you may not want to notify the parent, guardian, or caretaker. Such exceptions may include requests by law enforcement agencies or by DHS to use a different process, or determination by the mandatory reporter that for clinical reasons a different process notification is indicated. Such reasons might include the possibility that the perpetrator or others might flee with the abused patient, or that information documenting abuse might be destroyed. Exceptions to the notification procedure may also be made if there are concerns for the safety of the involved persons.
The final areas to be covered during today's presentation are assessment and outcomes. The healthcare professional gathers enough information to determine that there is suspicion that a child or dependent adult has been abused and files a suspected abuse report. The Department of Human Services, as specified in Iowa Code, is the state's assessment agency and is mandated by law to complete an assessment in cases where the suspected abuse occurred in a healthcare facility such as a hospital or mental health institute or a nursing home. There, in these settings, the assessment will be completed by the Iowa Department of Inspections and Appeals. DHS has the legal authority to request information from any person believed to have knowledge of a case of child abuse or dependent adult abuse, and that person is legally required to assist in evaluation upon the request to the department. After gathering enough information from observations, interviews, and documentation, and after assessing the credibility of subjects of the report, collateral contacts, and information, DHS must determine whether or not abuse has occurred. Each category of abuse requires specific criteria to be met in order to conclude that abuse has occurred. This determination is based on a preponderance of credible evidence defined as greater than 50% of the credible evidence gathered.
The Protective Services staff must make one of the following conclusions regarding a report of child abuse. Abuse confirmed and placed on the registry as a founded report. Abuse confirmed and not placed on the registry. Abuse not confirmed. Reports of confirmed abuse must be placed on the registry as founded child abuse under any of the following circumstances. Physical abuse where the injury was not minor or was not isolated or is likely to reoccur. Denial of critical care where the injury or risk to the health and welfare was not minor or was not isolated or is likely to reoccur. Mental injury. Presence of illegal drugs. Child prostitution. All sexual abuse except that committed by an alleged perpetrator less than 14 years old. Manufacturing or possession of dangerous substance with the intent to use the product as a precursor or intermediary. Bestiality in the presence of a minor. Allows access by a registered sex offender. Allows access to obscene material. The case was referred for juvenile or criminal court action. When there was a prior confirmed child abuse involving the same perpetrator in the prior 18 months. The perpetrator continues to pose a danger to the child named or another child. Within 12 months of the report, the county attorney or juvenile court initiated court action that resulted in an adjudication or criminal conviction. Reports of confirmed abuse shall not be placed on the registry as founded child abuse under any of the following circumstances. Physical abuse where the injury was minor and isolated and is unlikely to reoccur. Denial of critical care, supervision where the risk to the child's health and welfare was minor and isolated and is unlikely to reoccur. Denial of critical care, failure to provide adequate health care where the abuse was the result of the parents legitimately practicing religious beliefs. Reports where abuse is not confirmed shall not be placed on the registry as founded child abuse under any circumstances. Reports placed on the registry remain on the registry for a period of 10 years and sealed for another 8 years. Reports of confirmed abuse that were not placed on the registry are retained for 5 dormant years.
If warranted by the assessment, DHS may recommend some type of intervention. Voluntary services may be offered to the family, regardless of the outcome of the investigation. The types of services and treatment will vary depending on what the family needs and what the local community has available to provide in the way of support. In cases of suspected dependent adult abuse, the assessment process is very similar. The assessment will include interviews with the dependent adult, with the alleged perpetrator, if this is appropriate, and with other persons believed to have knowledge of the circumstances of this case. If it is determined that abuse may have occurred, the court may authorize evaluation of the dependent adult and the dependent adult's financial records. Upon completion of the assessment, dependent adult cases are founded, unfounded, and beginning July 1, 2007, a new category of founding, confirmed, not registered, was added. This additional category applies only to reports of physical abuse, including assault and denial of critical care. The new determination does not apply to self-denial of critical care where there is no caretaker. Any of the exploitation categories or any of the sexual abuse categories, including sexual exploitation of a dependent adult who's a resident of a health facility. Founded reports require a preponderance of evidence, that's over 50%, that abuse has occurred. Unfounded reports require a preponderance of evidence, over 50%, that abuse has not occurred. Confirmed, not registered reports require a preponderance of evidence, over 50%, that physical abuse or denial of critical care has occurred and is minor, isolated, and unlikely to recur. Confirmed, not registered reports are called assessments and will be kept on file in the local DHS office. These reports are not kept on the central registry. Confirmed, not registered reports will be kept in the local DHS office for 5 years and then expunged unless there is a subsequent report involving the same caretaker, and then will be changed to founded and placed on the Central Abuse Registry. Confirmed, not registered reports that are subsequently changed to founded and placed on the Central Abuse Registry will be sealed 10 years from the date the subsequent report was founded and placed on the registry. As with child abuse, voluntary services may be offered to the adult or the caregiver, regardless of the outcome of the abuse assessment. If the assessment reveals that abuse exists which might constitute a criminal offense, DHS is mandated to report to the appropriate law enforcement agency. County attorneys and/or appropriate law enforcement agencies are authorized to take any lawful action necessary or advisable for the protection of the dependent adult. This includes, but is not limited to, the initiation of court action for the appointment of a guardian or a conservator, or for admission or commitment to an appropriate institution or facility pursuant to applicable procedures in the code. Removal of a dependent adult. The Iowa Code provides for emergency protective services of cases of dependent adult abuse, which presents an immediate danger to the health or safety of the dependent adult, when the person lacks the capacity to consent to services or where no consent can be obtained. In such a case, the court can order the removal of the dependent adult to safer surroundings, order provisions for medical services, or the provision of other available services necessary to remove the conditions creating the danger to health or safety. If the department cannot obtain an emergency order due to inaccessibility of the court, the department may contact law enforcement to remove the dependent adult to safer surroundings, authorize the provision of medical treatment, and order the provision of services to remove the conditions creating danger to health or safety. A person, agency, or institution acting in good faith in removing a dependent adult or in providing services under this subsection, and employer of or a person under the direction of such a person, agency, or institution, shall have immunity from any liability, civil or criminal, that might otherwise be incurred or imposed as a result of removal or provision of services. Please answer questions 9 and 10 now. Dependent adults whose varied individual limitations necessitate assistance from others for basic tasks of living. And this has been a presentation about the healthcare professionals who are legally mandated to take action on behalf of vulnerable patients that they treat. Millions of people in the United States and hundreds of patients seeking care at this hospital each year are victims of neglect and abuse. It is our hope that this presentation has been helpful to you in the recognition and reporting of child and dependent adult abuse.